Right. Right, children, can you hear me well? Yeah? Right, excellent. Okay. Okay, right, fine. Okay, I think welcome. I think this is the 23rd or 24th session. Now I have lost count actually, right? So remember, children, we one moment. Right. We did initially the lower uterine tract symptoms, remember, right? We discussed what the symptoms are, and we discussed the pathophysiology, and we discussed the background about how to understand, how to define the lower urinary tract symptoms. Remember, we talked about urgency, urge incontinence, stress incontinence, how nocturia, what frequency means, all that we discussed. So if you are not familiar with it, please go to the lecture, the one, not the last one, but the one before, and you will get a good background as to what it means, right? I hope you all have listened to it. Then comes the second part of the lecture, which I discussed, stress incontinence, okay? So it is just one thing that is very, very common. Actually, more women present to us with stress incontinence than anything else, okay? So this is the third lecture of the series, because it has been 3 gynecology lectures, and then the next one we will go ahead with obstetrics, 1 obstetrics, okay? And then we will go alternatively into obstetrics and gynecology. So today's lecture or session is on overactive bladder, okay? So there are several definitions which you have to understand. Overactive bladder means that the bladder contracts on its own, right? Contracts on its own, and there is what we call urgency, right? And it contracts on its own, and therefore it can be without even urge incontinence. Just because it contracts, it doesn't mean that it has to that the woman has to pass urine. So the very fact that it is contracting, right, with or without incontinence, right, urge incontinence, is called overactive bladder, and it is often coupled with things like frequency, right, because all the time she wants to run to the toilet, right? And then sometimes it is coupled with nocturia, where she has to go to the toilet in the night, okay, or she needs to run, and other symptoms, so which cannot be explained by, say, a urinary tract infection, okay? So this is what means overactive bladder. Remember, it is not the same as urgency or urge incontinence, okay? It means basically the bladder is contracting, and then yes, you can have urgency, right? Because that is the feeling that the woman gets. May or may not leak, which is urge incontinence. Most of the time coupled with frequency. She has to go to the washroom many times, and also maybe coupled with nocturia. Do you all understand, right? And this happens, this overactive bladder or overactivity of the bladder happens in the filling phase of the cycle. So when the bladder is filling, when the bladder is quiet, and it should be quiet, it's not quiet, it starts to contract, okay? So this is the definition of overactive bladder. That is contractions or activity which occurs in the bladder in the filling space, right? With symptoms like urgency, there can be frequency, there can be nocturia. So all these are coupled together into this. You all understand, right? While the woman is trying to inhibit this voluntarily, she's trying to stop it. She doesn't want to do that. She doesn't want to run to the toilet, but yet it happens. Okay? So that is overactive bladder. Now there's also an understanding called detrusor overactivity. And this terminology specifically means it's a urodynamic diagnosis. You all understand? So it is not the overall name which we give. This specifically means, children, what? It's a urodynamic diagnosis. And how is urodynamic diagnosis done? You do urodynamic studies. Remember I told you, we put a catheter or pressure catheter inside the bladder. We put a pressure catheter inside the rectum that measures the abdominal pressure. The one inside the bladder measures intravesical pressure. If you subtract one from the other, you get an understanding called the detrusor pressure, right? And then when you do urodynamic studies, you will see that during the filling phase, right, when the bladder is filling up, you see detrusor activity, which may be provoked, might be provoked by something else, or unprovoked. It just happens, right? Say provocation may be anything, maybe even intercourse can provoke this. You don't understand? So it can be provoked or unprovoked, and you in the urodynamic study you see these contractions of the detrusor muscle. That is called detrusor overactivity. You all understand? This is a urodynamic diagnosis. So you need to understand the two things are separate, and so overall the whole complex of symptoms is called overactive bladder. Is that understood, children? So that I need to make sure that you got your definitions correct. Okay? Right. Now let's see how the bladder contracts. Okay, if you look at the pharmacology, right, very simply, we don't need to go into depth of it, right? The bladder has a detrusor muscle, okay? And it has receptors, which are called muscarinic receptors, right? And if you look at the genetic studies, there are 5 known muscarinic receptors: M1, M2, M3, M4, and M5. In the bladder, predominantly, it is M2 and M3. Of both M2 and M3 children, the one that is thought to be most responsible for bladder contractions is M3. Okay? Now, these receptors are present where? In the muscle fibers, right? And when they are stimulated, the bladder contracts. Okay? And how are they stimulated? The postganglionic nerve fibers, you know, there is a neuromuscular synapse or a junction, right? The nerves come and then they release certain things, and these certain things will go and occupy what? The receptors on the muscle, which are M3, right? And then that muscle will be stimulated for contraction. Okay? And what is released there, children? Acetylcholine, right? So the postganglionic nerve fibers will release acetylcholine, which will go and stimulate the M3 receptors, which will increase the bladder contractility. Okay? So there is basically a very rough idea as to what. From there, you have to understand one class of drugs, right, which will help in reducing bladder contractility is what? Anything that works against acetylcholine, right? Or any drug that blocks the M3 receptors without letting acetylcholine go and stimulate it. Okay. So do you all understand? So there can be competitive inhibition of acetylcholine. Acetylcholine is also trying to get in. Our drug is also going to get in. So it occupies some of the M3 receptors, acetylcholine also. So there's competitive inhibition. Fight dealer, you inhibit. Okay. Also, there are drugs that can cause problems with the increase the breakdown of acetylcholine. So it is reduced. You all understand? So these are all anything that blocks the receptors, right? Or blocks the action of acetylcholine can increase or decrease the bladder contracting. Is that clear? Right. So if you look at now, what is the nerve system that supplies these nerve ends to it, which are what? The parasympathetic nerve systems, right? So the parasympathetic outflow is from where? S2, S3, S4. Okay. So these are the nerves that comes out, right, from the S2, S3, S4 and innervates the bladder. And these are the ones that causes bladder contraction very roughly. Of course, there are other things that are there. There is something called C fibers also inside, which can cause contractions also, which we talk about later, right? And there's a huge amount of other physiological things which you need to know. Roughly, this is one. Now, what relaxes the bladder is the sympathetic nervous system. Okay, and the sympathetic nerves, right, are from the hypogastric plexus and the nerve. And what do? Basically, they stimulate the beta adreno. Those are beta receptor, beta adrenergic receptors. Okay, so this B3 or beta 3 adrenergic receptors, right, will relax the bladder. Okay, so from there, remember, there's another class of drugs which we'll talk later, which has an affinity and stimulates the beta adrenergic receptors. Okay, and this special drug is, we will talk about later, it's called mirabegron. There's only one at the moment, so that is one drug that stimulates these beta 3 adrenergic receptors. Is that clear? Right? So what you have to understand, children, right? And also there are something called C fibers also inside the bladder. They also have some activity which causes bladder contractions, and anything that blocks them can also cause bladder relaxation. So there's a special class of drugs which we put inside the bladder that modulates or blocks these, right, which we'll talk about later. So those are the three immediate class of drugs which you have to remember. Clear? So if you look at bladder contracted children, right? Okay, one moment, give me a moment. Okay, sorry. Right. Okay, where was I? Right. Okay, so we were talking about how the bladder works. So roughly, what you all have to understand, if I talk, if I just go it again, there are mechanisms that contracts the bladder, right? And these are mostly predominantly mediated by the parasympathetic nerves, S2, S3, S4 out. They go there, and these nerve ends in the the neuromuscular synapse, they release what? Acetylcholine from the postganglionic fibers. And this acetylcholine goes on to and stimulates what? The M3 receptors of the muscle, right? And there's a contraction. Got it? So all the drugs that inhibit this or has competitively block these muscarinic receptors will cause bladder relaxation. Okay. Then there is also specific beta receptor agonist, right? They can be called beta receptor agonist, right? These are mediated by normally the sympathetic nervous system, right? And these stimulate the beta receptors in the, especially the beta 3 receptors in the bladder. And when that is stimulated, the bladder relaxes. Okay. So any drug that causes stimulation of the beta 3 adrenoceptors, right, will cause relaxation. That is one way of trying to relax the bladder. Okay. And thirdly, what you are remembering is in the contractile process, there's something called C fibers, which are located inside the muscle as well as the urothelium. Urothelium is the inside the bladder. There's the epithelium of the bladder is called the urothelium. So in the junction between the urothelium and the bladder muscle, this C fibers seems to be having some effect as well. And therefore, anything that causes the blockage or modulation can and will cause bladder relaxation. So there's a special type of drugs trying to modulate those, which we will talk about. Those are, most of them will be have to be given into the bladder itself, right? Because this is mediated at the urothelium level. Got it? Right? These are the ones we put inside the bladder, and that causes bladder relaxation as well, right? So those are the things that you have to understand about the pathophysiology, right? Or the bladder contraction. Now from there, we need to go and think about the mechanisms as to why there is bladder overactivity. So there are various theories. Basically, nobody knows for sure. Okay. So that is the reason that there are so many types of medications, interventions, but nobody exactly knows why it happens. Maybe it's a mix of things. So basically, there are 5 theories, right? If you are asked about the pathophysiology, actually, right, there are about 5 theories that you need to think about. Number 1 theory, the first one, right? It's not number 1, but the first one, it is thought, children, that if there's somebody who has bladder neck obstruction, okay, for some reason, maybe the bladder neck descent or some problem with the obstruction of the outflow, suddenly the bladder muscle and the nerves change, right? Because they are trying to push the urine away. So these changes become a bit more permanent, right? And then there is bladder overactivity due to outflow obstruction. Okay, it might be a mass, it might be a fibroid, it might be, but that causes the bladder to change, right? When there's outflow obstruction. So the bladder also is trying to change and push the urine out, and then it causes overactivity, which is maybe one of the causes. That is number 1. The second one, it is thought, right, is that sometimes it is thought when there is a weakening of the bladder neck and when the urine falls into the urethra, right, there's a leakage of urine into the urethra, and suddenly it is thought, okay, since the urine is coming to the urethra, it is thought, okay, maybe the urine needs to come out. And so there is a connection between these, the urethra and the bladder, and it starts to contract. Okay, so that is the second theory. So it is urethra mediated bladder contraction. So if there's a continuous, if there's a weakness there and the urine falls into the bladder, the urethra, right, seems to be a feedback mechanism loop that causes bladder overactivity. So if there's a leakage of urine constantly into the urethra, it is thought that it causes bladder overactivity as well. Do you all understand? So that is the second theory. Lots of theories, okay? Third thing, it is thought due to certain reasons, the nerves themselves, right, has changed inside the bladder, right? Remember I told C fibers, all those, and the so that it's the nerves themselves are changed and they keep on firing. They keep on getting activated. because the nerves have chronically changed for some reason, right? So that is the nerve theory or neurogenic theory. Okay. Then comes the fourth person. Okay, okay. They thought the muscles have changed, right? For different reasons we don't know. Maybe due to some form of damage. So it doesn't. We don't really know. So it's called the myogenic theory. The muscles themselves have changed, so they are very, very active. Okay, so they are hyperactive and hypersensitive to stimulation. So that is the fourth theory. Okay, and then there is the fifth theory, right, which is the urothelium theory. Remember, I told you the bladder, there is a detrusor muscle, and inside there is the epithelium, which is called the urothelium, right? It is thought that when the bladder stretches, because the urothelium also stretches, right? The junction between the urothelium and the muscle, there is a change and a difference. And there are other fibers called C fibers, I told you, which get stimulated. And because of this, there is a contractility of the bladder becomes increased. Sort of the bladder thinks it's time to contract because the urothelium is also stretching, right? So it is thought that the basal part has a problem or a change and therefore causes premature bladder contraction. So those are the 5 theories. It's easy to remember, right? Every part of the bladder, it is thought there's a problem. If you look at it very quickly again, what? When there's outflow obstruction, the bladder muscle changes and there's overactive. Okay? If there's a weakening of the sphincters between the bladder and the urethra, if there's a urine coming into the urethra, the bladder thinks, okay, it's time. They have a feedback mechanism and its bladder thinks it has to contract. Okay? So it contracts. Third thing, the muscle changes, so it contracts. Fourth thing is the nerves change, so it contracts. Fifth thing, the urothelium stretches and there's a problem there, so therefore it causes muscle contractions. Do you all understand? So those are the 4 or 5 theories that is thought to be mediated. So basically, because there are so many theories, what it means is nobody really knows. Okay? Is that clear, children? Right. Okay. So now we have done away with what? The definitions. We have done away with how the bladder contracts and relaxes, right? And now we have discussed what? The theories behind the overactive bladder as to why it becomes like that. Okay? Clear? Right. From there onwards, let's go on to management, because diagnosis I have spoken about before, right? How do we manage? The first thing in the management is conservative management. Right? We try conservative management initially. And what is this? Remember, I told you about a urinary diary, right? So once we understand, okay, maybe the woman is drinking a lot of water or fluids, right? And mainly of these, 2 things. One is caffeine, a lot of coffee or even tea, right? And the second one, the problematic one, is alcohol. In Sri Lanka, it is not a big problem. Only in certain parts of the country, you might get women taking a lot of alcohol, right? But usually alcohol is not problem. So you need to restrict caffeine intake or you have to switch on to drinks that do not have caffeine. So you have to cut down on the caffeine. So, and you try to restrict the fluid intake to between 1 to 1.5 liters per 24 hours. But it might be difficult because restricting fluid intake might cause problems as well in the other side, right? Dehydration and problems. But basically, if she's drinking too much of water, right? One of the ways of managing that is to restrict fluid. So that those are the conservative management option number 1. Second one, which you can do, is bladder retrain. And how is the bladder retrained? Now it is, if the bladder is always contracting, right? What you do is you get the woman onto the ward, right? And you tell them, you give them time. Okay, this is the time you can go and do. So it's good to have a set of women, 2, 3 women who have this, right? put them in nearby beds, and then we tell, okay, now 8 o'clock in the morning, you can go and pee. So they all go and pee. Then you say, okay, now for 30 minutes, you can't pee. So there will be women who want to go every 15 minutes, 20 minutes. So you say, okay, 30 minutes, next time 8:30. Even if you leak, then you can't go. So for 30 minutes, they'll be holding up and waiting to go. And when you say, okay, 30 minutes up, zoom, they go. Do you understand? So then you train them for, then you tell them, okay, now, after they have trained for 30 minutes, then you say, okay, let's extend it for 1 hour. Right? Now, for 1 hour, you can't go to the washroom. Even if you leak, you can't go. So they will somehow try to hold you. Do you understand? So this is what is called bladder training. You extend the amount of time, or the between the pee times, right? Urination times. You just increase the time, and you try to retrain their bladder to have intervals of about 3 to 4 hours. And if you achieve 3 to 4 hours, then you can let them go home, but try to do the same at home. So variable success rates, right? The other option is to catheterize them and clamp the catheter. So the bladder gets a feeling as to how 30 minutes of bladder feeling is. Then you clamp the catheter for 1 hour, then 2 hours. So you train the bladder that way as well. So this is called bladder retraining, right? Mr. Viduranga, are you all right? Right? Oh, you have company. Good. So so you have, it's called bladder retrain. You all understand? So 2 conservative measures. What are they, Mr. Viduranga? Yes, he got disturbed, so he was not listening to you. Yes, what is the first conservative measure?
One is bladder. First one is urinary diuresis, and second one is bladder retrain.
Incorrect. Urinary diuresis is not a management option. Puta, it is the way you diagnose. I told you he had company, right? So that is for the diagnosis, Puta. The first conservative measure is restriction of fluids, okay? Caffeine and alcohol, okay? You missed that completely because you are, okay? Right. The second one is what?
Bladder retrain.
That you got. Now, because I mentioned your name, suddenly you are listening. So the second one is bladder retrain. Do you understand? So those are the 2 conservative measures which we can do. Right. So that is conservative management. So if you ask, basically 2 things, children. Fluid restriction, caffeine and alcohol, and the second, of course, is bladder retrain. That's all. Okay. Then we go on to medical treatment. So basically drugs. This overactive bladder, the mainstay is drugs. Right? This is what we use for the, right? So now let's look at remember, the drugs target certain aspects of bladder contractions or relaxation, right? So the first drug that we need to talk about is called tolterodine. Okay, these are all anti-muscarinic drugs. Okay, or anti-cholinergic drugs, things that work against the acetylcholine. Got it? What tolterodine does is, it's a competitive inhibitor at the muscarinic receptor. So it competes with acetylcholine, right, for a place in the muscarinic receptors. You all understand? So the acetylcholine also comes out, and then the tolterodine also goes there, right? And it competes for the places in the muscle. So the ones that are covered or occupied by our tolterodine does not cause any stimulation. Acetylcholine, when it connects, yes, there's some stimulation, but it competitively inhibits. Okay, so tolterodine is a very good drug, and it is also a first-line drug for us to use, right? And it is found in what? It is this drug is also used as a sustained release, once daily dose. You can give it, and it works for 20. So it has been made into a sustained release as well. You can give it in small doses, divided doses, or you can give it in sustained release. So these have been found to be very efficient, which we use. Got it? Remember, for anti-muscarinic drugs, the side effects are the problem. What are these? They behave, or since they block the muscarinic receptors, right? Some of them will also have other effects around them. What are these? Dry eyes. So the biggest problems are dry mouth, dry eyes, which will cause what? Blurred vision. Okay. Some will have tachycardia. Some will have constipation, because the smooth muscle of the bowel also might not work very well. Okay. So the biggest problem in this antimuscarinic one are what? Again, blurred vision, tachycardia, dry mouth, and constipation. So these are the ones that you need to be on the lookout for. So these are the commonest reasons why people stop using these drugs. Got it? Right. So tolterodine also will have those effects. Right. Then the next anti-muscarinic drug which is used is called tropsium chloride. Okay, it's an ammonium compound, but it's not a selective inhibitor. So it is a non-selective anticholinergic drug, and this is not very potent, so the effect is much milder. But this also it is also a very good drug, because maybe the side effects may be slightly less. So tropsium chloride also can be used as an antibiotic, but it's a non-selective. So it blocks all the receptors. Okay, if there is M2, M3, all this, so it's non-selective. So therefore, also there will be side effects in the other organs as well, but this is also can be used to a certain extent. Okay. Then comes the other drugs. One of the drugs that is being, so remember, the tolterodine is a competitive antagonist. Okay. Tropsium is a non-selective muscarinic receptor blocker. Then we have very selective blockers. It goes and blocks the receptor, and those are M3 specific blockers, and they have this effect on the bladder, right? And this is what darifenacin is one of those. Darifenacin and solifenacin. Okay, so solifenacin, darifenacin, and solifenacin are very potent M3 receptor blockers, which can also be used very effectively. These drugs are there, and their side effect profile is the same, but slightly less than tolterodine, and maybe slightly less than tropsium. So these are very good drugs that can be used, and they are in extended release forms are there, right, which can be used, right? Then in the same group, there's something called festoferidine, right? You don't really need to remember these names. Festoferidine also is one of the drugs that can be used there. So they are in the same group. Do you all understand? So in this whole group, we have what? Anti-muscarinic drugs. We have, that is all you need to know, children, right? We have competitive antagonists, which is tolterodine, right, which is widely used, right? We have tropsium, which is a non-selective anti-muscarinic receptor blocker. Then we have selective antagonists, M3 receptor selective antagonists, which are what? Darifenacin, solifenacin, and festoferrin, right? So those are the 3 drugs you need to remember. Got it? Right. And all these drugs can be used in certain different doses, different ways. There are extended release preparations, which can be very widely used. Okay. Then there's another class of drugs, right, which have a mixed different kinds of actions get together. It is not exclusively antimuscarinic. Okay, and these are the big these drugs with different actions. If you look different qualities, the main drug which we need to remember is oxybutynin. Okay, oxybutynin has anti-muscarinic receptor antagonism as well. Okay, at the same time, it has direct bladder muscle relaxation. And it is also has a bit of an anesthetic qualities. Anesthesia also, right? On the bladder muscle. Do you all understand? So oxybutynin is a mixture of these, but the biggest problem is its side effects are very potent as opposed to tolterodine, sulfasalazine, darifenacin, if you take it by mouth. But what has happened is it is comparable to all these drugs. But what has happened is because the side effects are more potent, people tend to hesitate. But now things are changing a bit because it has been found that if you change the ways in which you use oxybutynin, the side effects become less. And what are these ways? There are, yes, extended release preparations, number 1. There are gels that can be applied on the skin. Okay. There are patches that can be applied on the skin. So there are oxybutynin patches, right? There are oxybutynin gels, right? So there are different forms. There are different forms or routes in which to give this. And therefore now oxybutynin is again, things are coming up because it's an effective drug. Okay. So that is that. Then in the same group, there is something called propivarin. Now, propivarin, these are mixed action drugs, remember, right? Propivarin has 2 things. It has anti-muscarinic qualities as well as calcium channel blocking properties. It's a calcium channel blocker as well, okay? And therefore, it is also helpful in overactive bladder, right? Remember, so mixed action drugs too. What are these children? Oxybutynin, which has a direct muscle relaxant, anesthetic as well as anti-muscarinic properties. And although its side effects, which is dry mouth, dry eyes, blurred vision, also is very prominent if you give it alone. However, because there are different other types of ways in which you take, like gels and patches, it now again the side effects are less, right? And the other drug is propivarin, which has calcium channel blocking activities as well as anti-muscarinic activities. So this also can be used. Is that clear, children? So that is the second class of drugs which you need to think about. Okay. Then we have another interesting class of drugs. What are these? These are the ones, right, that has an effect on the C fibers, C nerve fibers, right? And these are, one of them is derived from chilies, the other is derived from a cactus, and the third is a toxin. Okay, what are these? Capsicum. Have you heard of this? Right? Chili salatine, right? So, one moment. Yeah. Right. Sorry. Okay, fine. So, where was I? Right. The other interesting class of drugs, right, are the ones that have an effect on the C fibers of the bladder, right? One is called capsaicin, right, or capsaicinum. I can't remember now exactly. Capsaicin, right? That is derived from the from chilies. Okay, so and how is that used? It has to be instilled into the bladder, right? Because it works between the urothelium and the muscle in between. Okay, so capsaicin, it's used, it's with mixed with a bit of alcohol and then put in the bladder. Okay, and it sometimes works for 5-6 months even. One single one single installation can work for 5 to 6 months, right? Capsaicin. Okay, the second interesting one is derived from cactus, right? And it's called resiniferatoxin, right? That has it's like capsaicin, but it is 1,000 times more potent. So which means you can put in a bit of it, but that's also is used to into the bladder. It's an intravesical therapy. You all understand? Right? So resiniferatoxin is also something that is instilled into the bladder. Okay, that also blocks the C nerve fibers and causes the bladder relax. These are therapies which is being used now. And the third intravesical thing to block these nerves and is what? Botulinum toxin. Have you heard of it, children? That also blocks these nerve fibers, relaxes the bladder, and it is, you put in a cystoscope and inject this botulinum toxin. It's called botulinum toxin, right? ono botulinum toxin, right? Or in the trade name is Botox. That is the one that is licensed for the moment, right? Or botulinum toxin type A. So all three are the same, right? This is injected into various points in the bladder by the means of a cystoscope, which has given very, very good results. Okay. So these are a bit of invasive therapies, but they work at a different level. Remember I talked to you about the C fibers, yeah, about the urothelium and the C fibers. So this is where it works. The next class of drugs, right, are the ones you thought is to stimulate bladder relaxation. Remember, children, I told you that there's one class of drugs which stimulates the adrenoceptors. Remember, the sympathetic system is mediated through the hypogastric nerve. Those nerves go and stimulate the beta, and they are beta adrenoceptors, okay, and or specifically beta 3. So when those are stimulated, the bladder relaxes. And so if we do have a drug, right, which works on these beta 3 adrenoceptors, right, the bladder should relax. And that is where a specific drug has come into play, and it is called mirabegron. Mirabegron. That is a beta 3 adrenoceptor agonist. You all understand? So this is a totally different way of approaching the problem. We are not trying to block the M3 receptors or block the stimulation. We are basically using medication to stimulate relaxation. Okay, so this has been used for overactive bladder. It's very effective, right? And that can be used, but it's expensive and it's not available in Sri Lanka, I think. But that is also a drug that is targeting this problem at the moment, right? So if you look at all of it, remember there's another drug which is often quoted, but there is not much evidence about estrogen replacement therapy. So estrogens to sort out overactive bladder is not something that is evidence-based at the moment, and we don't, but female postmenopausal women may have more increased overactive bladder. But estrogen therapy, giving estrogen therapy or starting HRT is not for the moment evidence-based, right? Although it is thought that estrogen deficiency also may have some role to play in overactive bladder, right? So remember that. So at the moment, we don't give replacement therapy with estrogen to treat overactive bladder. Okay, right. Now let's look at the drugs again in a very short summary. Okay, number one, children, anti-muscarinic drugs or anticholinergic drugs are the mainstay of treatment. Of these, tolterodine is a, remember, there is extended release form. It is a competitive inhibitor of the muscarinic receptors. Okay, so it's a competitive antagonist of acetylcholine. Understood? Then we have tropsium, right, which is a milder one, and it's a non-selective muscarinic blocker. Okay, then we have very selective M3 receptor blockers. What are they? Solifenacin, darafenacin, and festoferin. Okay, those are the competitive M3 receptor blockers, right? Then comes the other type of drugs. What? Things with mixed action. Of these, oxybutynin is the oldest drug which we have. What does it have? It blocks the muscarinic receptors, as well as it has a direct muscle relaxation effect and an anesthetic effect on the bladder. For the anesthesia, but the problem is the side effects are high when it's taken orally. But now, since the routes have changed, it has become a very effective gel thino, patch thino. Okay. The second one which we have to have mixed action is what? Propivarine. Propivarine manal karne. Antimuscarinic plus calcium channel blocker, which can also be used. Then the next type of interesting drug is what? The beta-3 adrenoceptors, right? Beta-3 adrenoceptor. Beta-3 එක stimulate කරනවා. Beta-3 stimulate කරනවා මොකද වෙන්නේ? Relax වෙනවා. So we have what? Beta-3 adrenoceptor agonists, and these are what is that? Mirabegron. Okay. Then we have intravesical blood ඇතුළට දාන drugs. What are these? Capsaicin, capsaicin, right? Capsaicin. Then we have resinoferatoxin, which is derived from cacti. Araka chili valley make cacti valley. And the thungenic is what? Botulinum toxin, which all inhibits the nerves there, which is very effective. Okay. Then those are the main things, but there are another one drug which you need to know is what? Tricyclic antidepressants. Tricyclic antidepressants is we use imipramine, right? And very rarely we can use amitriptyline, but imipramine is the most effective drug. And that has been found to be effective, right, in treating women with overactive bladder with predominantly nocturia. Rat urine pass when nocturia, we can add imipramine as a good drug. Okay. So it's a tricyclic antidepressant which has different types of action in the bladder wall. Okay. And the last drug which we need to remember is desmopressin. Desmopressin is an analog or a different way of vasopressin. Remember, vasopressin constricts vessels. This causes a reduction in nighttime urine production, and it becomes especially effective if it is used for nocturia and nocturnal enuresis in children. So desmopressin also can be used to treat overactive bladder, right? So this is all, children, that you have to know about the medication in overactive bladder. Do you all understand? Right? So that is the medication which you need to know about, right? Then the next one, right? So we have spoken about conservative management to put everything in perspective. We have spoken about the different drugs and how they act, right? And the groups. And the next one, we have also spoken about intravesical therapy, which is botulinum toxin. And then the next group is called neuromodulation. You stimulate the nerves and you do neuromodulation. And there are two types of neuromodulation. One is sacral neuromodulation. Sacral neuromodulation means what? You implant a neuromodulating gadget into the sacral plexus inside the pelvis. Okay? In the sacral foramen where the S2, S3, S4 nerves come out. And that stimulates these nerves. And because some nerves are stimulated more, the relaxation nerves, the sympathetic, than the parasympathetic, and the nerves of pelvic floor relaxation is stimulated more, you can achieve by neuromodulation bladder relaxation. But this is a very invasive thing. Imagine implanting something into the nerves in the pelvis, right? Which is a surgical procedure. So it's a very, very invasive thing. As opposed, so this is direct neuromodulation, but it is used when nothing else works. Okay, and that can be used. The second thing is peripheral neuromodulation. What does that mean? Now, there's a nerve called the posterior tibial nerve. Okay, you know what it is, right? You all are very good in your anatomy and neuroanatomy, right? And I'm sure that when I tell you, they will tell where it comes from, how it goes, and all that, right? But this interesting nerve, the posterior tibial nerve, comes out from the same roots, from L5 to S3. And they share a bit of a common pathway. So if you stimulate that nerve in the periphery, which is found under the just posterior aspect of the tibia, just 2-3 finger breadths medial to the medial malleolus. Right? So then you can put a needle there, right, with some anesthesia and stimulate that nerve. Right? Stimulation of this nerve causes bladder relaxation. You understand? So, kakule nerve, posterior cutaneous nerve, posterior tibial nerve, stimulate karala, you can relax the bladder. So they get sessions, right, where the bladder relaxation happens. So that there's a sustained relaxation and a very good studies have been done, and that also is an option, right? So what you all have to remember, children, is that what? There is direct neuromodulation, right, which is implantation of a device into the nerves themselves in the pelvis to modulate, relax the bladder. And there is peripheral neuromodulation, which is the what? Stimulation of the posterior tibial nerve. Okay? Finally, if that doesn't work out, finally the next one is surgical option. Okay? And what are these surgical options? There are only 3. First one is called clam cystoplasty. Bladder, you just cut it in half and put it in 2 sections. And in the middle, you fix an ileal. So one half of the other half of the bladder, and then you have a ileum stretched and sutured onto that. So basically a high pressure system is converted into a low pressure system. Problems, lot of problems. It's a very radical surgery. Bladder is cut in half, right? Immediately the low pressure system, there will be relief. But then there is, from the ileum itself, there will be mucus production, sometimes malignant change, maybe all those problems might be there, right? But if you go for these systems, the woman must be ready for intermittent clean self-catheterization, so that she needs to, if there's a retention, right, not contraction, but retention, she needs to be able to self-catheterize. So she needs to be ready for that, okay? Any woman going for these surgeries need to be ready for intermittent self-catheterization. The second one is called myectomy, right? Detrusor myectomy. You cut the detrusor completely without cutting the mucosa, and you separate that. So basically, you have cut the muscle, so that there is then there is only the mucosa and a slight sort of layer left, and that causes bladder relaxation, which is called detrusor myectomy. And then the third one is the clamp cystoplasty, then detrusor myectomy, and the third one is putting a urinary diversion. How is that? Because if the bladder is not working at all, it is causing a trouble and a problem. You basically divert the urine onto a different, so urine diversion, where it can be diverted into a pouch made from bowel, it can be diverted into the appendix, it's called metrophanoph. So basically you have a urine diversion, right? And the urine can be diverted into a different pouch, and then the opening is made on the abdominal wall, and she needs to intermittently empty that from the urinary diversion or that pouch. You understand? So the ureters will go into that pouch, it's avoiding the bladder completely, and you have a different pouch, and then she will have to intermittently self-catheterize. So therefore that is called urinary diversions, right? So these are the things that can be done for women with overactive bladder. So now to put everything into perspective, children, right, since we have gone through all this, what is the practical approach that we do? Number one is the diagnosis. So go back to my first lecture and see what the diagnosis, how it's made. Okay. Once we have a diagnosis, right, either by our clinical or by urodynamic studies, then the first thing we need to tell them is what? We try the conservative measures. First of all, you try to adjust their urine, the fluid intake, right? Cut down on their caffeine and alcohol, right? And then next, you give them 6 weeks or so, even 4 weeks or 6 weeks of bladder retraining. Okay, do you understand? 2 to 4 weeks or 6 weeks of bladder retraining, because sometimes the success rate may be high as 90%, sometimes between 40 and 90%, right? If she is obese, you ask her to lose weight. Losing weight also will help in bladder relaxation, right? And at the same time, in women with mixed incontinence, you ask them to do pelvic floor exercises. That at least for 3 months. Okay. Fluid restrictions, right? Try to avoid caffeine, right? And alcohol. You start on the pelvic floor exercises as well. You ask them to lose weight, right? And you send them for a course of bladder retraining. You all understand? Right? And then if these are not successful after a period of time, maybe 6 weeks up to about 3 months, you try with all this. And then you add the medication. And the first line medication now, normally 3 types, right? Which is tolterodine is a first line drug, right? Oxybutynin is a first line drug. Solifenacin, darifenacin, all these are first line drugs which you can add, right? If you give them a trial, right? For these drugs to act, it takes time. So the next review of any drug should be between 6 weeks to 8 weeks. And sometimes some will even give it for 10 weeks. But normally the review, you ask her to come back to see what is happening to her in about 4 to 6 weeks, right? And then when she comes back, and then she tells, okay, things have not changed or she has improved. If things have improved, you can, but not enough, then you can increase the dosage of the present drugs, whatever she's taking, right? Because maybe an increase in the dose can give us more effect. And then you review her again about 2 to 3 weeks. You all understand? Or if the maximum dose of those initial first line therapy has not worked, right? Then you have to review those drugs and change them over to different drugs. This is the time where mirabegron comes in, right? So you can try beta-3 adrenoceptor drugs, right? Stimulating drugs, especially mirabegron. Or you can try sustained release or different kinds of other drugs which are used, okay? At the same time, if you have nocturia, you can think of imipramine, okay? So do you all understand? So then you put these into effect. So then the next step would be, once you have tried these also, and if it is not helpful, then the next step, children, right? You have tried them for some time, right? You have gone for the second line drugs as well, right? And still, if it is not effective, then you have to think of intravesical instillation, which I told you about, right? Right? So you use that, and then the capsaicin and the other drug, right, is not very much available, but botulinum toxinum is available. In we also do it in Sri Lanka. Okay, if that is not effective for this woman and not enough, only then you need to think of peripheral neuromodulation, which can be used. Okay, but normally we don't go for sacral implants because we don't have those basically, but that is done in the last resort. That's the last resort. And if that is not working out for her and the quality of life is so low, only then with expert opinion and with a lot of people involved, you have to think of either direct sacral neuromodulation or the surgeries like clamp cystoplasty or what it is, myectomy, or if none of these, then the last option, children, is to go for what? Urinary diversions. Do you all understand? Do you all understand the pathway in which we go, right? So most of the time, we don't need to go through that pathway. It's highly unlikely that we reach the surgical stage. Most of the time, we can control a lot of the symptoms in the initial stages, right? So this is basically overactive bladder and what you need to understand about the overactive bladder and its management. Okay, is that clear, children? So in this topic, there are other things which you need to read by yourselves. There is continuous leakage of urine. Those are fistulas, right? You can have vesico-vaginal fistulas due to certain trauma. You can have uretero-vaginal fistulas. You can have uretero-vaginal fistulas. You can have uretero-peritoneo-vaginal fistulas, right? All these require surgical management. Okay. Then there is neurogenic bladder or overflowing continence due to the muscle of the bladder getting damaged, or the nerves that in a way the bladder has got damaged due to different reasons, right? And those are called neurogenic bladder, which you need to, those are overflowing continence, which you need to also read up and see what. Those are very, very short topics which you have to understand in this about these urinary problems. Okay. So basically, I think I have covered everything that you need to know. Those are the things that you need to read by yourselves, right? And that should cover everything that can be asked from you all concerning the lower urinary tract symptoms, concerning stress incontinence, and concerning overactive bladder. Okay, so we have finished that topic. So next we will go to children, we will go to what is this? An obstetric topic next. Okay. Any questions? Yes. Any questions, children? Mr. Viduranga, you missed the conservative management first part, huh? Right. So I think enough for today, right? Yeah. So is that clear? Any problems? No? Okay then. Good night then. Okay.
Thank you, sir.
Okay. Good night.